name is Kaho. Last name is Taolo. I'm from Botswana, but I'm actually based in Johannesburg, South Africa, training as a radiologist. So I'm a registrar at Wits University, based in Johannesburg. So that's a little bit about me. So today, the way we are going to do our session, we will allow our presenter to finish his presentation, and then at the end, we will allow for questions and contributions from the audience. And so this evening, we are fortunate to have Dr. Gerald Boitshepo giving us a talk. Dr. Gerald is a colleague and friend from Botswana. He trained in Prague, Czech Republic, in Europe. That is where he got his undergraduate degree. And then he went on to do his postgraduate training in Australia, in University of Sydney in Australia. So currently he's based at Princess Marina Hospital, holding a registrar position. So Dr. Gerald, please, the floor is yours. Thank you very much.
Yeah, thank you, Taolo, Dr. Taolo, for that. Like Dr. Taolo has said, I'm currently at the registrar level, and I'm quite honored to be given this opportunity. I was contacted by David, who I understand is still traveling now due to some family matters. He invited me to give this presentation platform. I was quite honored about that, more so that, as I just had, that it's the last presentation of the year. I guess it's a closing. As much as I'm pleased, I think the closing, the curtain call should be rather fire. But I think mine will just be lukewarm. But without further ado, I'll go on and to start the presentation. And for the first bit, it will be a little interactive, and I hope we can just share our thoughts a bit. It will be a short presentation, so yeah. Let me go on to share my screen. All right, I hope everybody can see my screen now. If at all somebody is not able to view it, please let me know. So my presentation will be on focal intracranial lesions, mainly viewed using the computed tomography. So that will be, we'll do a case review on that, and then go on to the meat of the presentation. This is a presentation that I had done before, but and I thought I could share it again once given this platform because of the seriousness that I take it for, and the complications that I've seen during my work in Princess Marina due to it. So as my professor usually says, focal lesions in the brain or any other place, any other organ in the body, that are categorized into 4 categories and 5 categories in the lungs. We found that we have this focal lesions of an infection, contusion or trauma, and neoplasm. These are the 4 main categories that could cause a focal lesion in the brain or any other organ in the body. The 5th category, or the 5th group that we have that cause a focal lesion in the lungs, as I had outlined, is due to atelectasis. So that is the only area where we find this 5 causes of focal lesions in the lungs, whereas in the brain or any other part of the body, there are 4, as I've already stated. My presentation, as I said, it will start with a case review that I had seen in the hospital. A 12-year-old male presented to ED in a rather somnolent state The history was that he had had fever for a few days, and then started experiencing flu-like symptoms, and then went into the swollen state, and then a gradual loss of a decline in GCS. So this was the CT brain that was done upon arrival in Princess Marina Hospital, which is the biggest referral hospital in Botswana and Gaborone. It was referred from a nearby hospital, about 30 kilometers from. So if anyone can kindly just drop or just unmute and tell me what they think, or just write in the chat box what they think about this kid's brain. We just need to vote. It's either you choose a subdural, whether it's a subdural hematoma or a subdural empyema. Okay. Let me see if there's anything. Nothing in the chart. Okay, I'm going to continue sharing. So this is a question that we'll get to answer as we go on in this presentation, whether this is a subdural hematoma, a subdural empyema, or in other cases, a hygroma. This child went on because he was in respiratory distress. A chest X-ray was done, and these were the findings. The clinician at the time diagnosed this chest X-ray as a probable pneumonia. I'll go on to explain the case in detail, but basically this is the gist of my presentation today. I'll be talking about type of a focal lesion, which is a subdural empyema. So we're talking about focal infections of the brain. These are brain infections are usually walled off. They can either be in the parenchyma or in the extra cerebral space, either in the subdural or epidural space. Imaging considerations that we need to keep in mind are either CT, which is usually the first imaging that we do in patients who present with this such symptoms, or in other settings, MRI, but the workhorse in this management are CTs. So basically, a subdural empyema is a suppuration in the pre-existing space between the dura and the arachnoid. So this can also be known as meningitis antenna or purulent meningitis. It's a serious illness associated with frequent neurological sequelae, resulting in mortality rates up to 10 to 20%, which is why I stated that it's I've seen such mortalities due to this infection. It constitutes to about 13 to 23% of all intracranial bacterial infections. This, ladies and gentlemen, is a surgical emergency, and everyone who is involved in the management of such cases should be aware of it, because anyone, be it the imager, the radiographer, the treating clinician, the specialist or the junior, should be able to identify patients who present as such. So this is just the basic anatomy outlining the subdural empyema, where it's located. We can see from this image that it poses, it could be confusing where it is, whether you see it, you'd assume it's a subdural hematoma, which is what that case was diagnosed at, or it is, especially in the young, that is a subdural hygroma. So the etiology of a subdural empyema, it's usually supratentorial. Most of these infections occur from outside the brain. It is generally a secondary spread. The biggest contributor to this infection are paranasal sinus infections. This is due to the small vessels that communicate either the frontal sinuses or the frontal sinuses or the ethmoid sinuses with the intracranial space. Other causes could be from otitis media mastoiditis, extending from there, that is a direct spread. And other causes could be due to trauma or iatrogenic. Iatrogenic, that means post-operatively, a patient now gets a secondary infection, and then it will develop into a subdural empyema. There could be subdural effusion. Sometimes meningitis evolves to form subdural empyemas or the subdural abscesses. There could be hematogenous spread. That means a patient who has had a super infection, they are quite septicemic, and then through the blood vessels, through the blood, this infection reaches the brain, but this is then a very small percentage. Usually the presentation, which most of us here would meet these clients in the radiology suite or in the radiology department. From the history, you'll see that the patient had presented with temperatures that are quite high, feverish. They've had headaches, they've complained of headaches before that were initially focal and later generalized. I believe that most of the radiographers as well in the department are always eager to look at the patient history. So it's always good to appreciate the history, which will help in the better imaging and better provision of what could be done for that patient at a certain time. There could be a recent history of sinusitis, otitis media, mastoiditis, meningitis, cranial surgery or trauma, or previous sinus surgery. The patient will present with confusion, drowsiness, stupor, or even in coma. Some may have hemiparesis or hemiplegia, seizures, focal or generalized, nausea and vomiting, blurred vision, speech difficulties, or have had a history of intracerebral abscess. These clinical features are due to, that they would have features of raised intracranial pressure. Due to this evolution of a subdural empyema, that there could be signs of raised intracerebral pressure, which is why the patient may present with this nausea and vomiting. Meningeal irritations, the patient would have this meningism or meningeal signs such as stiff neck, blurred vision, or photophobia. There is focal cortical inflammation as seen in the enhanced studies of the brain. Pathophysiology of this condition, like I had already alluded, subdural empyema most often occurs due to direct extension of local infection. The infection can spread to the intracranial compartments due to the valveless diploic veins of the breast head. These are the vessels that I said allow for communication between the frontal sinus and ethmoidal sinuses. As a result, blood may flow in either directions, thereby causing the spread of bacterial infection intracranially. I already alluded that this can also occur post-surgical intervention. The investigations involve routine blood. We'll see elevated leukocytosis with left-sided shift and neutrophils. The CRP will also be elevated. Usually LP is not indicated. The workhorse in this is imaging, which is why this infection is very close to to our field. Imaging modalities, like I said, CT scan is usually the one readily available, and MRI can be used in case of availability. CT scan findings, they are typically hypodense, concentric in shape, resembling subdural hematomas. They have ring enhancement, uniformly following contrast administration. Evidence of sinusitis is usually present. So this is a typical imaging that you would see in a patient presenting in our department. There is that opacification of the right maxillary sinus in the first photo on the left, showing presence of sinusitis. The sinusitis actually was extending to the frontal sinuses. In the second photo, you can see subdural collection as well as midline collections, indicating those subdural, the subdural empyema. There are all this other array of tests which not really part of us, but just for your knowledge. There needs to be culture sensitivity to determine the kind of treatment to give to the patient, the kind of organism that you're dealing with. Sometimes you have culturing of those paranasal sinusitis just to appreciate, the organisms that was residing or that is responsible for that infection. This is, like I said, a neurological emergency. Early surgery, craniotomy, cranectomy for evacuation of the empyema is warranted, followed by antibiotics, vancomycin, and third generation cephalosporins. This is continued for about 4 to 6 weeks, and follow-up scans to be planned during this period. Now I'll go back to my case review. The scan, CT scan, showed subdural empyema. The chest X-ray showed neurogenic edema. Neurogenic edema is a sequelae or a complication of a subdural empyema that once the patient has it, sort of shoots just raises the mortality of patients presenting with subdural empyema. So the reason why this case was of importance for me to share was that this patient was seen in ED with those symptoms. The initial examination that was done by the ED doctors or the clinicians in emergency was that they ordered the chest X-ray. The chest X-ray came back with that diffuse airspace disease in the lungs, and they queried a pneumonia. There are very few pneumonias that present diffusely in the lungs, and those are usually viral. In it, the etiology is usually viral, and it is less likely to have such manifestation. So this was a rather peculiar case to think of a pneumonia in. Then a CT brain was done because the patient was presenting with this decreasing GCS, and that collection was identified in the brain. So there were differing thought process. The others thought this child had a hygroma or a hematoma and had a separate case of diffuse pulmonary pneumonia. Another thought process was that another attending reviewed the CT scan as it being an abscess, and that this abscess was due to the lung infection. But after review of this case and understanding the subject, the pathophysiology, you understood that the presenting symptoms of this child, which was this acute sinusitis and having all this upper respiratory tract infections, resulted in him having a subdural empyema. And due to this empyema, he developed neurogenic edema as a sequelae of the subdural empyema. As an attending or as a radiographer or radiologist reviewing this case, it is imperative to be able to include or have subdural empyema, especially with neurogenic edema, as part of the differential, because, like I said, it results in a very in increased level of mortality if not attended to. This patients, once craniotomy and evacuation is done, they tend to have rather good recovery. Even the neurogenic edema resolves on medications to challenge it. So like I said, my presentation was short. It was just to give everyone an idea of other differentials to consider once we see what looks like crescentic findings on brain CT. Because provision of this be either at any level as a part of differential to the treating team can greatly reduce the possibility of mortality. The thing is also the subdural empyema mostly affects the young, because those are usually the ones that are affected or are predisposed to developing sinusitis. So with that, we have seen, I had done this presentation before in the hospital and in Princess Marina, and after doing it, there was an increase in patients, the finding. It was like there were suddenly more cases presenting as subdural empyema, but I think before we had been overlooking them and we're able to manage them. That I've seen a couple of cases that have recovered after craniotomy and evacuation of the empyema. Unfortunately, this case that the case review that I did, the child demised because we were worried about treating the pneumonia and thinking that the brain collection is just a hygroma that we can find, that we usually find in kids of this age. With that, I'd like to take this opportunity to thank you for this opportunity to give a presentation. And yeah, that is just one of the hobbies that I like doing. I think at this point in time, we can go on to do some discussions or have some questions. Thank you.
Well, thank you so much, Gerald, for this beautiful talk. I want to believe this kind of a talk will take us somewhere, and most importantly, it will help our patients. At this point in time, may we allow questions and contributions, please? Thank you. The floor is yours, audience. You may type if you want to type, or you may just raise your hand. I can already see a hand from Webster. Webster, please, the floor is yours.
Thank you. And thank you for the nice presentation.